Bismillahirrahmanirrahim. Assalamu alaikum, respected seniors and dear colleagues. I am Dr. Mehvish Gilani from Armed Forces Bone Marrow Transplant Center. I am honored to be a part of this esteemed conference and moderating this industrial talk session. For this, I would like to invite Dr. Nasir Abbas Bukhari, an accomplished graduate of Nishtar Medical College. He has done his fellowships in pediatric medicine, pediatric hematology oncology, and bone marrow transplantation. He has contributed to numerous research publications at both national and international levels. Currently, he is serving as an associate professor and heads the pediatric bone marrow and stem cell transplant unit at Children's Hospital and University of Child Health Sciences, Lahore. Sir, please.
Bismillahirrahmanirrahim. I'm Dr. Nasir Abbas. Today we are going to discuss the role of cyclosporine in bone marrow transplant and beyond. So today we will discuss what is bone marrow failure, what is aplastic anemia, how it is diagnosed, what is treatment options available, and different articles of cyclosporine role in bone marrow transplant and its role in GVHD prophylaxis. So what is bone marrow failure syndromes? जैसे नाम से भी जाहिर है bone marrow failure. Bone marrow is unable to perform its work. So they are the syndromes as a result of inherited or acquired condition resulting in the hematopoiesis failure. So it includes aplastic anemia, myelodysplastic syndrome, and myelodysplastic syndrome is sometimes called myelodysplasia. Aplastic anemia is a rare disorder, and in Pakistan, it is almost 3.5 cases per million. And myelodysplastic syndrome again is very rare, but with the passage of time, with age, after 60 years, its incidence is increased. So, aplastic anemia. This is a hematological identity with the bone marrow. Aplasia, naam se zahir hai, aplasia ke cells are lost in bone marrow. So, when we say the aplasia, अगर किसी को हम कहते हैं aplasia है तो एक चीज़ हमें cellularity ज़रूर mention होनी चाहिए. Percentage of cellularity. सिर्फ ये नहीं कह देना कि this is aplasia. We must mention this is 10% cellularity, 15%, 20% to know the exact therapy available. For the diagnosis of the aplastic anemia or bone marrow failure, first of all, bone marrow biopsy, with refined biopsy, and we have to rule out the other causes of the bone marrow failure by immunophenotyping, by FISH, to rule out PNH. So, the treatment options available for the aplastic anemia include the allogenic stem cell transplant, not autologous, only allogenic stem cell transplant and immune therapy, immunosuppressant therapies. Currently, allogenic stem cell transplant is mostly being used as well in Pakistan with matched sibling donor. And if matched sibling donor is not available, then other options are matched unrelated donor transplant. But in Pakistan, matched unrelated donor transplant facility is not available. So we adopt either haplotransplant or immunosuppressant therapies. So this is the treatment options available in children. We can see that if very severe aplastic anemia is diagnosed and we have matched sibling donor is available, we should proceed for matched sibling donor transplant. If matched sibling donor is not available, then what are the options? Either matched unrelated donor, which is not available in Pakistan. It can be done, but it's not available right now, and we need special permission from HOTA if even matched donor is available who is out of family. But the immunosuppression therapies are available. If matched donor is available, bone marrow transplant. If not available, immunosuppression therapies. We check response for 6 months. If there is response, yes, continue. If there is no response, again matched unrelated donor or haplotransplant, which is available. But in adults, it's a bit different. In very severe aplastic anemia, if the age is less than 40 years and matched sibling donor is available, proceed for bone marrow transplant. And if age is more than 40 years, we can consider matched sibling donor transplant, yes or no, but other therapy in the form of immunosuppressive therapies along with eltramapag should be used. And if there is response in 6 months, proceed. And if there is no response, then and patient is eligible for transplant, we must proceed for bone marrow transplant. And in less than 40 years, map-sibling donor is available, transplant. If not is available, age is less than 20 years, which may be mean different institution may have different protocols. We may have haplotransplant or match only to donor transplant. And if age is 20 to 40 years, it can't be considered, but immunosuppressive therapies can be used. So there are some different articles to treat for the treatment of strategies and use of immunosuppressants in aplastic anemia. This is article by my friend Dr. Rahil Memkamrisa, which shows again that when we decide about the treatment options in aplastic anemia, we must assess the age, comorbidities, donor availability, and the probability of response to immunosuppressant therapies. And again, if sibling is available, bone marrow transplant is first option. Otherwise, match only to transplant or haplotransplant can be used. So when we do bone marrow transplant, whether this is with sibling, whether it's unmatched related donor or or haplotransplant, GVHD prophylaxis is required, especially in every transplant. So GVHD prophylaxis in HLA match sibling calcineurin inhibitors like cyclosporin and Birol is a commonly used first-line treatment. In some centers are using different medicines, but cyclosporin A is the commonly used medicine along with the methotrexate, mycophenolate, or antimetabolites. So this is the impact of cyclosporin A concentration in T-cell replete haploidentical. This is very important कि हमारे लिए सिर्फ ये नहीं है कि साइक्लोस्पोरिन इस्तेमाल शुरू करनी है, साइक्लोस्पोरिन यूज़ करनी है. इंपॉर्टेंट ये है कि उसके लेवल भी अचीव होना चाहिए, उसके लेवल भी मेंटेन होना चाहिए. And this will show that if the cyclosporin level, you can see, if the cyclosporin level is less than 200 nanogram, usually we keep in 200 to 400 nanogram per ml. If the level is less than 200 nanogram per ml, the chances of grade 2 to 4 GVHD is very high. And if the level is above 200, but of course not more than 400, otherwise toxicity will be developed, the chances of grade 2 to grade 4 acute GVHD are less. So this is another article which shows the impact of the early cyclosporin A levels on the acute graft versus host disease in the allogenic stem cell transplant immovable T cell depletion. So ये चीज समझने की जरूरत है कि this is week 1 cyclosporin level and this is week 2 cyclosporin level. You can see we have to maintain the cyclosporin level high in week 1 as well in week 2. If this is week 1, if this level is more than 200, you can see the chances are low of low GVHD. But same in week 2, if the levels are more than 200, chances are low. And if the levels are low, less than 200, the chances are very high of acute GVHD. So along with transplant, the cyclosporin is also having role in different autoimmune disorders. बल्कि एक और चीज़ मेरे ख्याल में आप लोगों को एक्सपीरियंस भी होगा, आप शेयर भी कर सकेंगे. वो use cyclosporin as a single therapy in some patients, especially who are not having very severe aplastic anemia, in moderate to severe aplastic anemia. और हमारे children hospital हमने देखा कि 12% patient responded only to Birol, only to cyclosporin as a single therapy, means even without ATG. So हम सब यही करते हैं कि if when patient is diagnosed an aplastic anemia, हम बस folic acid B12 के साथ cyclosporin start करा देते हैं, and some patients respond or they don't need bone marrow transplant. So FDA approved indications for the Birol include the different kidney as in kidney, liver and heart allogenic transplant, rheumatoid arthritis, psoriasis, autoimmune hemolytic anemia, chronic ITP. Chronic ITP में I don't know कि आप लोग कितना experience है. हम लोगों ने experience किया है, देखा है कि when patient develop chronic ITP and he of course need therapy, the cyclosporin along with low dose steroids, something alternate steroids is well tolerated and responded. Nephrotic syndrome and uveitis. So these are some indications of non-FDA approved indications, but it is being used. Allogenic conjunctivitis, the LCH, ocular graft versus host disease, autoimmune hepatitis, Duchenne muscular dystrophy, ulcerative colitis, red cell aplasia. I don't know आप लोगों का कितना experience है. Pediatrics में वो use cyclosporin along with the steroids as a good treatment option for the treatment of pure red cell aplasia. प्योरोरेट एप्लेजिया में जो पेशेंट्स थे जिनको हमने स्टीरॉइड शुरू कराए, दे रिस्पॉन्डेड वेरी वेल, मगर जो ही हमने स्टीरॉइड बंद करने शुरू किए दे रिलैप्स्ड। उन पेशेंट्स हमने देखा कि वी स्टार्टेड अगेन स्टीरॉइड्स along with cyclosporine, then we gradually tapered the steroids, and cyclosporine was continued for about 1 year, and they responded very well. So it can be used in red cell aplasia as well and HSPs. So what should be the dose of cyclosporine? जो हम वायरॉल की बात करते हैं, वायरॉल हमें पता है कि दो में अवेलेबल है, आईवी फॉर्म में और ओरल फॉर्म में। आईवी फॉर्म में वो इनिशियली यूज इन आईवी cyclosporine at usually day -1, which is 12 hours pre-transplant at 5 to 6 mg per kg for dose, and post-transplant until patient control rate oral therapy 2 to 10 mg per kg. But again, this is range. We have to maintain the trough or peak levels. And in oral, if IV is not available, IV cyclosporine is not available, बाज़ पाकिस्तान में नहीं available होती IV cyclosporine, we use oral cyclosporine pre-transplant again 12 hours before transplant, but this is usually high dose, usually 14 to 15 mg per kg by mouth, 1 to 2 weeks post-transplant, 5 to 10 mg per kg per day in 2 divided doses, and of course we maintain the levels, try to maintain the levels, and by week after 6 months we reduce gradually 5% per week after 6 months of transplant. So thank you very much. एंड हमारा मेरे ख्याल में आप लोग कुछ लोग बैठे हुए हैं जिनका शायद वायरॉल के साइक्लोस्पोरिन का सभी ज़्यादा एक्सपीरियंस होगा। अगर आप लोग उसमें ऐड करना चाहें, शेयर करना चाहें, मोर देन वेलकम।